Hello and welcome. I'm Joseph Grace. It's a pleasure to share this session with you, and thank you for the invitation in the first place. I have no conflicts of interest to declare, and here are my affiliations. Now, we're all experts in managing complex venous disease. However, this talk will focus on the nuances of aesthetic sclerotherapy or aesthetic phobology. Let's go. Here are the examples. Corona radiata, facial, can be quite severe and extensive. Approximately a third of the patients who present to our vascular practice actually have an aesthetic concern. Of these, about half of them have an underlying venous complaint or venous issue, saphenous reflux, etc. 3/4 of all complications are usually due to persistent underlying venous reflux. And, of course, post-sclerotherapy necrosis is more frequent with aesthetic procedures, and hence the medico-legal complaints are more frequent there. It's worthwhile emphasizing that the skin is comprised of a well-defined complex network of vascular and lymphatic structures, and it's worthwhile respecting. Let's look at some core principles. Assessment. Duplex ultrasound mandatory. The venous map will help identify underlying root veins which need to be treated first before addressing the surface veins. I ensure that this is explained and communicated to the patient properly well before treatment. Of the sclerosants, you've got STS and polydocanol, a detergent, a surfactant. I use STS in my practice, 0.12% for telangiectasias and 0.5% for reticular veins. I treat regions or staging. I basically no retreating too early, and this actually also addresses the needs for reducing risks. By also treating the reticular feeders first before downstream telangiectasias, and of course allow for healing time. Sclerosant power is defined. I use it to describe pretty much the injection pressure, sclerosant foam or not, concentration, etc. They're all the factors that go towards achieving chemical ablation. Remember that there's a narrow therapeutic window between a dose that produces no effect, the desired effect, and then of course side effect. The consent process is more than simply a form. It should include a frank discussion covering number of sessions, healing time, pigmentation, the need to release trapped blood, etc. In Australia, procedures must include a detailed fee assessment every time. Remember the paradox of litigation, and that is, it's often higher in minor cosmetic procedures than it is in major. Complications or adverse events. Hyperpigmentation is the one to watch out for with aesthetic sclerotherapy, and it may be caused by transient hyperproduction of melanin or melanogenesis, and this occurs in the epidermis of the basal layer, which we'll see shortly, and of course hemosiderin, which occurs in the dermis and hypodermis. Here it shows the melanocyte. Here it shows the actual melanin granules, which get taken up by the squamous cells as they undergo keratinization. Here, this slide shows the hemosiderin that is present in the dermis and hypodermis, and this unfortunately is the cause for more permanent staining. Matting is also related to usually high sclerosant power. However, you need to keep in mind that some individuals are more susceptible, including keloid hypertrophic scarring, autoimmune conditions, scleroderma, dermographia, very rare but it's hereditary, and highly atopic individuals. In sensitive individuals, I use non-steroidal anti-inflammatories, antihistamines 3 days prior, during, and then of course after, in the attempt to reduce the degree of angioneogenesis. Although there is no proof to show that works, I feel it has anecdotally been of advantage. Skin necrosis. Although this is rare, it may be serious, and it is a serious complication because there have been reported limb and appendage losses. So unfortunately, this is something that we need to be very careful of. The mechanisms underlying, you need to understand that there's the direct arteriolar injection, which really should rarely ever happen under ultrasound guidance. The ischemia resulting from extravasation, which is also not usually a major cause, but the veno-arteriolar reflex and vasospasm, which has been well described here, and the papers are there. This slide perfectly shows what actually happens if you inject with too high a sclerosant power. You can see the central area is at risk of pigmentation, matting, and skin necrosis. And then, of course, you have this outer part, which is ideal concentration, which gives optimal outcomes. And then, of course, beyond that is, of course, no benefit or no effect. In conclusion, as we've seen, aesthetic phlebology is of great importance to patients in the vascular surgical setting. We need to respect the three pillars: thorough assessment, meticulous and refined injection technique, and of course proactive management and of patient expectations. By applying our best practice standards and developing deeper understanding of the dermis and its vascularity, I'm confident that we can master the nuances of aesthetic sclerotherapy. Ladies and gentlemen, thank you so much for your time. It's been my absolute pleasure. Welcome to Sydney anytime. Thank you. Done. All right.